Welcome to the APP broadcast. We are here at the second annual APP conference here in Nashville, Tennessee. My name is Jessica Glennie. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio, and I work with the Interstitial Lung Disease Clinic there. I'm joined here by some colleagues, Naomi and Cori. I'll throw it over to you guys to introduce yourself. Naomi?
Okay, thank you. I'm Naomi Miyazawa. I'm a physician assistant, and I currently work at the Children's Hospital, Colorado in ambulatory pediatrics. My specialty is more kind of general pulm, asthma, and a little bit of pediatric ILD.
And my name is Cori Fratelli. I'm a nurse practitioner at National Jewish Health in Denver, and I specialize in interstitial lung disease.
Okay, so today we've got kind of three different topics, but they all kind of come together. So we've got Naomi is gave a talk on pediatric ILD, Cori on ILD 101, and myself on ILD 102. So I'm going to throw it over first to Naomi. Naomi, tell us a little bit about your talk. Tell us a little bit about ILD and pediatrics, something we talked about that I'm really interested in because I don't know too much about it.
Oh, okay. Yeah, sure. Well, actually, my talk is tomorrow afternoon, so this is kind of a nice rehearsal for me. And I guess the one thing that I want to emphasize is that ILD in children is not at all like adults. I feel like people think about interstitial lung disease and think of kind of the worst outcome, people walking on oxygen and everything. But in children, I think it's important to know that ILD can present in many different ways. And it's not uncommon for ILD in pediatrics to present in the neonatal period. These kids often present with severe respiratory distress. And, you're like, gosh, why is that kid breathing so fast? Why is this baby on oxygen? And you kind of rule out all the common things and everything. And what you're left with is, maybe this person has, or this patient has a pediatric ILD form of disease. And we call it child. So children with interstitial lung disease. And so when we think about child, or we use the terminology child, we refer to these little, these pediatric patients who have kind of a severe respiratory symptomatology that we have not yet defined. And with, genetics, all the genetic testing that I think has really helped us to make these diagnoses earlier. When they're younger, we are able to then provide treatment for them, put them with a multidisciplinary team so that we can give them better quality of life, preserve lung health, and so that they can grow into adulthood and hopefully at some point find a cure for these young people. So.
Wow, that's wonderful. So I first want to say, CHILD, what a great acronym and how ILD lends itself so well to creating that acronym for pediatric ILD. So in adults, we really think about these diseases as pretty severe, pretty poor prognosis, poor survival. Is that true of the ILDs that you see with children as well?
Yeah, certainly. I think that there are some disorders that obviously, these babies don't survive. But there are some other forms of, pediatric ILD that are often associated maybe with other systemic diseases or your autoimmune rheumatologic types of diseases, growth abnormalities, which maybe aren't as, lethal we still need to know what the underlying cause is. We still need to provide them with the appropriate, care, management team approach and support them throughout so that we can give them the best quality of life. I think that there are many children, unfortunately, that we have seen whose quality of life is compromised, limited. Some have gone on to have, lung heart transplants. So it's very life-changing, but, we try to support them as best we can. And
in adults, I think we worry a lot about progression and how fast progression occurs. Is that something that comes up in conversation with the pediatric population quite a bit?
Definitely. I think, we try to monitor them frequently. of course, when they're younger, that we're kind of limited on some of the diagnostic testing that we can do, but certainly we do a lot of imaging. We do a lot of looking at biomarkers, different types of cells and stuff, either through bronchoscopies, blood work, doing some genetic testing, that hopefully someday, we can learn from them. We also have this kind of national registry where all the, national pediatric centers who deal with these rare diseases in kids, we put them in these registries so that we can learn from each other and say, well, this pattern fits this type of a diagnosis. And this is what we found treatment-wise to help these kids. And then we also learn from the adults too on all the, research and studies that you do with different anti-fibrotics. Well, could that possibly work in our pediatric population too?
It's so interesting that you mentioned the anti-fibrotics because, what I'm thinking is treatment-wise, what are we using for the kids? And you mentioned autoimmune diseases for some of these. So I imagine potentially you're using some immunosuppression. Sounds like maybe not anti-fibrotics, but what kind of medications are you generally using for these kids?
It kind of depends. So oxygen, number one.
Yep, great.
Steroids. So sometimes you just kind of have to stop that inflammatory process. And so we'll, do induction with high dose IV steroids. We'll use some of these other rheumatologic, all these NABs and stuff we can use. Azithromycin, hydroxychloroquine. So we'll use maybe a combination of those types of things to see if that kind of helps to, help with their disease state. Sometimes we'll, we do a lot of collaboration with our rheumatologists. And so certainly if there's underlying reason or biomarkers or something that might lead us to think that they might be responsive to some, rheumatologic therapies, we'll go that way too.
I think it's an interesting segue into sort of the adult world when you talk about medications. Of course, I was talking on the basics of ILD, that ILD 101 kind of thing. And the one thing I like to stress is that there's a fibrotic process, which is the scar, and then there's the inflammatory process. And it's to our listeners, you're naming all of these drugs. And I encourage our listeners to go back and replay that beginning part because I want you to think, are we listing these in inflammatory spaces or in places where that helps the fibrosis? And that is probably one of the things that sort of leads into adulthood is those inflammatory drugs that is trying to tamp down the inflammation of the ILD. It's important through the lifespan, which I've never really considered before.
Yeah, no, I think that's what's most important in our pediatric world is that, we are trying to prevent the fibrotic process so that, they can, make it into their adult world. So yeah, we do use a lot of these anti-inflammatories. And we do, unfortunately, we do see a lot of these kids as they grow a little older have more of a fibrotic type of disease. And we actually are using one of the anti-fibrotics already in some of our kind of older children.
Yeah, I hadn't thought about, the trials. I'm not sure if they recruited younger patients, maybe 18 and older, potentially. Do you have any issues with getting these things improved for any of your patients that have need to be on them? Or maybe you don't have quite enough of them on to know, but...
Well, actually, we did participate in one of the clinical trials.
Oh, wonderful.
The nintedanib one. And so I think down to the age of 16.
Oh, great.
So,
Okay.
they weren't the little ones, but, at that age, we are able to get CTs and perhaps biopsies to confirm the diagnosis of, fibrosis. So,
Okay, great. So, Cori, you spoke a little bit about ILD 101. Let's go a little bit into the adult world. So tell us a little bit about your talk. You said you were doing a little bit more of kind of the basics of ILD, but give us kind of the big talking points for your talk.
Yeah, I think the big talking points when you think about ILD, because it's such a big world, is I like to put things in sort of boxes or clouds. And I do like to separate the scar from the inflammation process as a starting point to think about, okay, well, how do I break all of that down? what would be my triggers for, scar process? What would be my triggers for an inflammatory process? And then you get into the idiopathic kind of zone, and then the autoimmune inflammatory kind of zone, or hypersensitivity pneumonitis. And once you have your tree set in your head, I go further a little bit and I put on my investigator hat. I feel like I'm a detective and I dive deep into history. I think that's really important. I think we often overlook, okay, what are the exposures that they might have caused the interstitial lung disease, not just genetic, but the exposures, do they have animals such as birds that might be an issue?
We always like to talk about the birds, don't we?
We do like to talk about them. This is where you need to insert like bird music.
Bird, yeah, that's right.
Yeah. Won't charge you for that one. And so once you think about all the triggers, even occupational hazards are quite large and extensive. Then once you figure that out, you have to think about testing, right? How do I think that they might have this interstitial lung disease process. They come with me with cough, shortness of breath, and like, how am I going to figure this out, right? And I think just a baseline chest x-ray to just see, okay, what am I looking at? Like, is it nothing acute? Like, I don't have a pneumonia. I don't have anything odd that you're seeing in the chest x-ray overtly. Oftentimes, patients with ILDs are misdiagnosed with pneumonia, and we need to dive a little deeper. And that's where definitely getting a high resolution CT scan is important. So once we get imaging, it's a way for us to then begin to classify the ILD, because the high resolution CT scan is like gold standard for saying, okay, this patient has interstitial lung disease. The thing is, though, is we can't keep getting scans to see if their ILD is progressing. It's just high radiation risk. So an annual scan is really important. And of course, if things change over the year, then you can get more repeat scans. But how are we tracking these patients throughout the year is really important. So we think about pulmonary function testing and walk testing as well. And so when we think about just these basic ways to investigate ILD, diagnose ILD, and then track it, we get patients on a routine follow-up schedule. It makes it pretty easy to see how their ILD is evolving. And then we can think about medication management, whether it's anti-fibrotic therapy or immunomodulatory therapy. And that's when things kind of get in the weeds and your talk enters, right?
Yeah, that's right. I have to say, I had a really hard time deciding what to do for ILD 102. I wasn't given direction, and there's so much I could talk about for ILD 102. It's like being in a store and seeing all the different kinds of cereals and you don't know which one to choose. So I decided actually to do a case-led study, and with a patient that I've been taking care of for years. And it allowed me to kind of talk about some of the newer guidelines. And one of the frustrating things about interstitial lung disease is, for a long time, we didn't have any guidelines, and we still don't have a lot of actually approved medications. So we have some approved medications for the anti-fibrotics, and maybe you could say some of the immunosuppression, like rituximab for RA, et cetera. But, for a lot of our immunosuppression, we don't have a lot of guidance. So that's something that's very frustrating for me. And so I chose a case study that would help to kind of highlight that, and maybe my thought process going through taking care of a patient with an autoimmune interstitial lung disease. And, maybe a little spoiler, but my case was about a patient with dermatomyositis, antisynthetase syndrome, and kind of went through the ACR guidelines. These are new guidelines by the American College of Rheumatology that help to kind of highlight, what are our first line drugs, our second line drugs, alternate kind of drugs that we can use for our patients, and really help to give, some guidance in that kind of a patient for that inflammatory pathway. So then I also went into the anti-fibrotic, the fibrotic pathway as well, because unfortunately this poor patient developed fibrosis that continued to progress. And so I chatted a little bit in my talk about progressive pulmonary fibrosis and kind of our new guidelines for that too. So it's so cool. We've got these guidelines now. And then this poor patient, got worse again. And it turns out she had pulmonary hypertension. So then I was able to kind of go over pulmonary hypertension ILD with this patient. So I thought it was kind of a cool way to kind of go through some of the new guidelines, some of the new treatments that we have, but with, kind of this case of this poor lady.
I think I'm even more confused now than I ever been about ILD, because you mentioned several specialties that I'm not sure our listeners understand how they fit in. For example, pulmonary hypertension and rheumatology.
Yeah.
How do they get involved in ILD?
Yeah, absolutely. So, well, you talked about kind of that tree and doing that good history. So, when we're thinking about diagnosing our patients, that history includes assessing for underlying autoimmune diseases. So there are certain autoimmune diseases that can cause interstitial lung disease. So big ones, big players are scleroderma and myositis, but also rheumatoid arthritis, Sjogren's, lupus, mixed connective tissue disease. And so when we're seeing our patients with our physical exams, we really have to look at their joints, look at their hands, ask about their joint symptoms, ask about their skin symptoms, their muscle symptoms. I mean, we're like trying to be like little rheumatologists as well, because those can also cause our lung problems. And then unfortunately, patients can also get group 3 pulmonary hypertension with interstitial lung disease. So there's some remodeling of the pulmonary vasculature, as well as some destruction of the pulmonary vasculature in patients with interstitial lung disease that can cause the pulmonary pressures to go up. So double, triple whammy for all these patients of diseases.
So what I'm hearing is that we collaborate more with other specialties, especially in the adult world. Does that happen, Naomi, in the pediatric world too?
Definitely, because we do collaborate a lot with rheumatology, immunology. Our colleague, our sidekick right here is always our pathologist and our radiologist, because we too, rely on these high-res CTs to kind of help us, figure out what's going on with this poor child. But we always live in that multidisciplinary world, collaborating with our colleagues, because, like in adults, it's confusing. There's a lot going on. We hate to miss something. And, in pediatrics, we too look for underlying systemic diseases, all these rheumatologic, autoimmune type of stuff. We always are making sure that they're not developing PH, because, that's just another horrible disease that these kids have to manage too. So, we're always, making sure we're getting those echoes regularly, and when they're old enough, doing pulmonary function testing, assessing their level of activity, sleep studies. Yeah, it's a lot for these families.
A lot of comorbidities that they can have. It really portends a worse outcome if you don't catch them, and you want to make sure you're treating them. And Cori, I know I always call on you for this, but I think it's really cool that you have a pretty good collaboration with your rheumatology colleagues, right? How does your collaboration go in your center?
Yeah, we sit in the same room with them. I'm completely spoiled.
That's so nice. Yeah.
So if I have a question, I literally turn around and tap them on the shoulder, which I know not all centers have.
Yeah. I think that's really why things like this, APAPP and RAP, which is the Rheumatology APP conferences, are so important. Because, if you meet somebody in the ILD or rheumatology world that, knows a bit about this, that maybe you can grab their cell phone number, you can get that contact, and you can contact them when you need a call a friend, right? And it's just so exciting to meet other people who are doing what you're doing too, and really leading the way to empowering NPs and PAs to, work at the top of our license and be the best that we can. So I think it's so important to come to APAPP in 2026. Everybody should come and join in 2026. Last words, any other pearls, thoughts from talks, things you would like our listeners to know?
I have to say that one of the big things I learned from APAPP in collaborating with my colleagues is that RAP in 2025 is happening soon as well. So it's a good opportunity in the next few months, because in September, I believe, start then, meet people at RAP, get excited for APAPP next year.
Yeah. I mean, if you're listening to this, you may very well have some interest in ILD or, autoimmune-related ILD. So RAP's a great place to go for lots of great information. So that's it for our podcast today. But please sure to tune into other podcasts, and please be sure to check out the APAPP conference in 2026 and come meet all of your colleagues there.